Good afternoon. My name is Dr. Ramatisho Aibu, a consultant endocrinologist at the National Hospital in Abuja, Nigeria. And I'll be talking about endocrine cancers today. I'll be beginning with thyroid cancers, which are the most common endocrine cancers. For occult thyroid cancers, the prevalence rate found at autopsy is between 5 to 10%. In Hawaii and Japan, prevalence can be as high as 28%. About 2% of thyroid cancers occur in children and teenagers, and the male to female ratio is 3 to 1. These are the different types of thyroid cancers: the differentiated ones, papillary and follicular, the undifferentiated medullary, anaplastic, rectal cell, and the lymphoma and sarcomas. The risk factors include radiation, family history, obesity, and hereditary syndromes. It could present as asymptomatic nodules, a change in voice, secretory diarrhea and flushing in medullary thyroid cancer, or simply a hard and firm nodule or dysphagia. The investigations include thyroid ultrasound, thyroid scintigraphy, CT MRI, fine needle aspiration biopsy, thyroglobulin genetic testing, and calcitonin levels. Treatment involves the TSH suppression using levothyroxine, surgery, radioiodine, and chemoradiation therapy. Now, the parathyroid cancers, they are quite rare. Only about 1% of parathyroid tumors are malignant. Most are idiopathic and sporadic. They are associated with MEN1, MEN2, and the hyperparathyroidism Joy tumor syndrome, and associated with the tumor gene HRPT2. This is the clinical presentation: a neck mass, lymphadenopathy, and features of hypercalcemia. The investigations include a parathyroid level, serum calcium, CT PET scan, DEXA scan, sestamibi scan, and the treatment is parathyroidectomy and en-bloc resection of the ipsilateral thyroid and any adjacent tissues, and medical treatment as palliative care. Now, the adrenal cancers, these are also rare, with an incidence of 0.7 to 2 cases per million population in developed countries. They usually present late with metastatic disease. 40% are non-functional, 60% are functional. The functional cancers present with fever, abdominal pain and fullness, weight loss and back pain, while the functional ones also, in addition, would present with features of an endocrine system, an endocrine syndrome like Cushing's syndrome. These are associated syndromes: Beckwith-Wiedemann, Cowden, familial polyposis coli, and the MEN syndromes. The investigations include testing for Cushing's syndrome, testing for primary hyperaldosteronism, and so on. The treatment includes surgical resection, chemotherapy, and treatment of the various endocrine syndromes. The neuroendocrine tumors are malignant tumors derived from neuroendocrine cells. They occur mostly in the GI tract, also in the lung and the pancreas. They produce serotonin and chromogranin A, which serve as biomarkers. These are some of the functional neuroendocrine syndromes, like the carcinoid Zollinger-Ellison syndrome, Cushing's syndrome, Werner-Morrison syndrome. The signs and symptoms: abdominal pain, diarrhea, flushing, GI bleeding for the gastropancreatic, for bronchopulmonary, cough, hemoptysis, and recurrent infection. These are the lab investigation: chromogranin A and the 5-HIAA test, also imaging CT MRI, gallium dotatate PET/CT, endoscopic ultrasonography for the diagnosis of pancreatic neuroendocrine tumors. The treatment for localized disease is surgery and adjuvant chemotherapy. For metastatic disease, it's surgery and the use of somatostatin analogs, targeted biological therapy, tyrosine kinase inhibitors, and so on. Now, the gonadal tumors, ovarian and testicular. Ovarian cancer is the most common gynecological malignancy in the US, the second most common in the US, and the third most common gynecological malignancy in the world. Mortality is high, and the risk factors are advanced age, early menarche, late menopause, family history, obesity, hormone replacement therapy, smoking, endometriosis. The histological grading, from unable to assess the grade to well differentiated, moderately differentiated, and then poorly differentiated. It can present without symptoms, with abdominal fullness, nausea, change in bowel habits, urinary symptoms, lymph nodes, system Mary, Joseph's nodule, or the sign of lesser trillet. The investigations include a complete blood count, metabolic profile, tumor markers like the CA125, CEA, alpha fetoprotein, genetic testing, transvaginal ultrasound, MRI, and CT. The treatment, debulking surgery, adjuvant chemotherapy, hormonal therapy, anti-angiogenic inhibitors, and other types of treatment. Finally, the testicular cancers, which is a common malignancy in men aged between 15 and 45. It represents 5% of urological and 1% of male cancers. And the incidence in the United States is 6.3 per 100,000 persons in 2017. The incidence is higher in developed countries and in Caucasians. And this is the WHO histological classification of testicular cancers, from germ cell tumors right down to miscellaneous non-specific stromal cell tumors. And this is the presentation: a painless lump or a painful lump, anorexia, malaise, weight loss, and when there are pulmonary metastasis, cough or shortness of breath, cervical or supraclavicular lymphadenopathy, or bulky retroperitoneal disease can present as back pain. Vascular obstruction or thrombosis can lead to lower extremity edema. So these are the investigations: alpha fetoprotein, beta HCG, immunohistochemical markers, and for imaging, testicular ultrasound, abdominopelvic ultrasound, and abdominopelvic CT. The treatment consists of orchidectomy, chemotherapy, which could be cisplatin-based, and radiotherapy for brain metastasis. That brings us to the end of this short video. Thank you very much for listening. These are my references.